wisdom. You are welcome to the part 3 of demystifying glaucoma, the past, present, and the future. I'm sure you've watched part 1, part 2, and part 3. So this is my third series that is live, that is going live. My first series was on visual loss of unexplainable cause, about 4 to 5 part series. The second was headaches and associated disorders, about 5 part series, and then this is the third series I'm doing currently, that is glaucoma, demystifying it, what we know before, what we know now, and what the future holds for us in the treatment and the management of glaucoma. So this is the third part of it. Do well to watch part 1, part 2. Also, please, I encourage you to subscribe to the channel, to comment, like, and share the video to as much as you can reach. So in our last class, I began to teach on several things. So I don't want to go back to it. Just go to the channel and watch the part 2 of it. So today I want to dive into something more complex than what we did the last time. So today we are going to be looking at the types of glaucoma, and if I'm able to give an overview of it, and then we'll go to the next point of view. For those who have been asking, don't worry, the slide will be out once I'm done with the series. The same way I gave out the slides for headache, the slide I used for headache, I prepared them myself, I did them myself, and then the slide for this will also be ready so that you can also go through in your spare time, and it will also have a way of guiding you in your clinical practice. So the slide will be shared after I'm done with the series. So today we are looking at the types of glaucoma, and there are basically 3 types of glaucoma. According to research, there are basically 3 types. The first type of glaucoma is the primary developmental or congenital glaucoma. So congenital means that it is from birth, that the child was born with glaucoma. So yes, it is possible for a child to be born with glaucoma. It is very, very possible. It's not just something associated with elderly people. A child can be born with glaucoma. And the second type of glaucoma is the glaucoma associated with congenital ocular anomalies. So there are ocular anomalies that can lead to glaucoma. And then the third is developmental glaucoma associated with systemic anomalies. So this is the 3 types of glaucoma. I'm going to be breaking them down, explaining them for everyone to be able to understand. So let us look at the first type of glaucoma, which is the primary congenital glaucoma. So this refers to abnormal high IOP, which usually results to developmental anomaly in the angle of the anterior chamber. And then usually is dependent on the onset. Remember, we are looking at the primary developmental or congenital glaucoma. So the onset is very, very key. It's critical to understand the onset, and it helps us in our diagnosis. So there is the newborn glaucoma. In other words, the baby is born with increased intraocular pressure at birth. You understand? It's at birth, and in most times we see it in 40% of the cases. So a child is born with increased intraocular pressure, and then there are subtle signs you're going to see that will want to check the pressure of a child. There are subtle signs which I'll talk about later. So that is for the newborn glaucoma. And then there is infantile glaucoma, which manifests prior to the child's 3rd birthday. So before the child clocks 3, you begin to notice glaucoma. It is called infantile glaucoma. And then the third is juvenile glaucoma, which is a case whereby the pressure rises after 3 years, but usually before adulthood. So you see a child who was born fine, age 1, age 2, but after 3 years you begin to see signs of glaucoma. So that is the glaucoma we call juvenile glaucoma. And it is important that we understand these different types and then know how to treat them effectively. So what are the clinical signs we are going to see? Because children cannot talk, children cannot express themselves effectively. So the best they can do is to cry. The best they can do is to give you a sign that they are comfortable. So what are those signs we look out for? It will also help the mothers to able to look at these signs when they give birth to their children. So what are those signs we as doctors want to look out to know that a child is probably a glaucoma suspect or a child has glaucoma? The first is tearing, photophobia, and blepharospasm. So, at birth, the lacrimal gland is not yet developed. So, any tears you see at birth is not tears. It is something else, because the lacrimal gland is not developed until about is it 3 months now or 3 weeks? I'm not so sure, but at birth, the child cannot produce tears. So once you begin to see tearing at birth, photophobia, high photophobia, so the light is passed around the child and the child forcefully closes their eyes, it is one of the signs of glaucoma at birth. And again, blepharospasm means the twitching of the lids. So it is also a sign that the child might have glaucoma. So we are not saying that every time you see blepharospasm, you see photophobia and tear, you say, oh, this is glaucoma. No, we are not saying that. It is the doctor who will assess it and say the child has glaucoma. And then another sign we are to look out for are corneal signs. Is corneal signs such as edema. So edema means that the cornea is hazy in appearance. The cornea is transparent. The cornea is not black as people think, or it's not even brown or blue. The cornea is a transparent structure. What gives the cornea that color you see is the reflection of the color of the iris. So the cornea should be transparent at birth, even till old age, it should be transparent. But in a case of hazy cornea at birth, it is an important sign we must look out for in the clinic, and it shows that it's pointing that the child could also have glaucoma. Also, when there is an enlarged cornea, so you see a cornea that is larger than normal, there is a normal cornea size at birth. But when you see a cornea that is larger than normal, it calls for query, it calls for concern, it calls for questions. So it is expected that the clinician should run further tests once he sees a cornea that is larger than normal. And also when there is decimate breaks. So the decimate membrane is one of the layers of the cornea. The first is the anterior layer, the second is the Bowman's, the third is the corneal stroma, the fourth is the decimate membrane, and the fifth is the endothelium. And again, there is the Duas layer, which is hypothetical, but I'm sure research is going on the Duas layer. But my emphasis this afternoon is on the decimate membrane. So when you see the breaks in the decimate, it is also pointer to indicate that something is wrong. So corneal edema is usually the first sign which will arise, which will begin to give suspicions. Usually the first sign you see, and then the doctor wants to query why it is so. Also, corneal enlargement is also another important factor. Also, when we see tears in the decimate membrane, also known as Harp striae, it is we want to know why is this so, why is it happening, and then know what to do from there. Also, another signs we look out for in a clinic for glaucoma in children or in infants is the sclera. So when the sclera becomes too thin and appears blue due to the uveitic light underlines the sclera. Now, but in children, most times the sclera is not as thick as it should be. So there are times you might see cases of blue appearance of blueness in the eyes in newborn, but when it is obvious that these eyes are blue in color, it is also a sign that glaucoma is there. And also, we also want to look at the anterior chamber. So the anterior chamber is also important to in determining if the child has glaucoma. And the iris may show iridogenesis and also atrophy patches in the late stage. So the iris may show, you see the iris as if it is jerking or it is vibrating. It's also a sign of glaucoma in infants. Also, the lens might appear flat due to stretching of the zonus. So you want to these are the ophthalmoscopic features you begin to see. The lens appears flat because the zonus has been stretched. they are stretched beyond normal, and then it appears the lens appears flat in appearance. Also, the optic disc can also be a sign we want to see in cases of glaucoma. So the optic disc, you might see a large cupping, which is not normal for children, and also atrophy, especially in the third year. So it is also one of the signs we want to check out for. Again, the intraocular pressure, which is the hallmark of it. The intraocular pressure is most in such cases usually high, but even if the pressure is normal and then we are seeing these signs, we still want to question and query what is going on. And again, axial myopia might occur because of the increase in the axial length, which may give rise to anisometric amblyopia. So you begin to notice axial myopia because of the change in the length of the eyeball. So these are one of the things we want to see. So what do we do when we notice these signs in the clinic? First of all, we want to check the pressure. And for children, because they are children will always be children. So there is this they won't allow you to conduct the test well. So a general anesthesia is very, very important. In fact, some authorities will tell you that it is compulsory that a complete examination should be done under general anesthesia, so that the child is kept still, and then the practitioner can do a thorough case on the patient. So first of all, we want to anesthetize the child, and then we want to check the pressure. I've already taught on the normal pressure, 10 to 21. So Shaw's is usually preferred. It's usually preferable. Shaw's tonometer is usually preferable for children. The research is saying that Shaw's is better. So we want to do the Shaw's tonometer and then know what the pressure is saying. So, and again, the next test we want to measure the cornea diameter, because if you are saying the cornea is large, it must be a reference. If you are saying the cornea is bigger than normal, what is your reference point? We need to know the normal circumference of the cornea, and then we are now saying, okay, in view of this, if the normal is maybe 11 millimeter and 10 millimeter, this is what we are getting. So we want to measure the cornea diameter with calipers. Also, we want to also do a slit lamp examination. So a slit lamp examination is done, and it is best done with a portable slit lamp. So we want to view the structures in the eyes, and after that we want to also do ophthalmoscopy to view the optic discs, know what's going on there, and be able to document effectively. Also, gonioscopy is important too, so that you can check the anterior chamber of the eyes. So now, having done this, it is expected that the clinician comes up with a differential with a diagnosis. But then there are cases that are not glaucoma, but yet they might present with such similar appearances. So we want to look at the differential diagnosis. So don't worry, the slide will be out. The slide will be filled with pictures so that you can appreciate whatever I'm saying. You can see the pictures for yourself and be able to run with them. So for the case of a cloudy cornea, what are the differential diagnosis? Now, if it is unilateral means it is just one eye. So the common case is trauma. And again, in most times when there is a case of trauma, you will see that decimate tears we talk about. So if there is a trauma, trauma can also lead to a cloudy cornea. So we are not saying that every time the cornea is cloudy, it is glaucoma. So we also need to know that trauma can also cause a rupture of the decimate membrane, and then lead to a hazy cornea. And if it is bilateral, it can also be trauma too, or it can also be interstitial keratitis. Interstitial keratitis can also lead to bilateral corneal edema, or it's also a corneal endothelial dystrophy. It is a kind of pathology affecting the cornea. So you know the corneal endothelium is responsible for, it serves as a guard preventing fluid from entering. The cornea has a way of keeping the endothelium of the cornea rather has a way of keeping the cornea transparent. Now, if there is a damage to the cornea endothelium, it means that fluid can be retained in the anterior chamber, in the anterior portion of the cornea and other portions. So any damage to the cornea endothelium will lead to corneal edema. So if it is bilateral, so probably there is a corneal endothelium dystrophy leading to the accumulation of fluid in the cornea, making it hazy. Also, large corneas can also be due to ophthalmos. So we should also note that in the case of ophthalmos, large corneas can be present. Also, megalocornea, sclerocornea, and high myopia. In these cases, you find out that the cornea is larger than normal. So not every time we see a large cornea, we say it's glaucoma. So ophthalmos, megalocornea can also appear as with a big cornea. Also, lacrimation in infants is usually due to the congenital nasolacrimal duct drainage when the duct is blocked. So if the duct is blocked, there will be also, it means that the tears, it means that the drainage is blocked, then you begin to see the tears being produced. It can no longer flow out. Do you understand? It begins to come out as a before. But remember I said earlier that in newborns, there is no tear production. So it is after some months or some weeks, you begin to notice the lacrimation. So, but if the child is 2 years, the child is a year old, where the lacrimal duct has been developed, and yet you are noticing that lacrimation, it might not necessarily be glaucoma. It could be due to a blockage in the nasolacrimal duct. So, also, when there is a foreign body in the cornea, it can also lead to tearing, that is corneal abrasion. Also, when there is what's called Meesmann corneal dystrophy, can also lead to lacrimation. So, raised IOP in children can also be associated with retinoblastoma. So, retinoblastoma is like the cancer of the retina. So, in such cases, there are also times whereby you see a raised intracranial pressure or retinopathy of prematurity. Sorry. So, in retinopathy of prematurity, we see is a case whereby the child is born premature, and because the child is born premature, the vessels of the blood vessels are not yet developed. So the structures of the eyes are not yet developed. In other words, there is hypoxia. There is limited oxygen supply to the patient, to the child's retina, and because the retina requires a high level of oxygen supplies, then there is now what we call neovascularization. And then in neovascularization, you know that the blood vessels are very fragile and they grow rapidly. So the blood vessels can begin to grow rapidly and then block the obstruct aqueous outflow, leading to glaucoma. So optic disc changes can be differentiated from congenital anomalies of the discs. Like there's a coloboma. We should not mistake coloboma for optic disc anomaly, hypoplasia, tilted discs. All these are, and also physiological cupping. So the cupping can also be physiological. So these are the things we want to rule out before we can say the child has glaucoma. So if we have been able to diagnose an infant, a juvenile, or a baby of glaucoma, what is the treatment plan? So the treatment plan is usually surgery for children. For such kind of infants, it's usually surgery. So we refer to an ophthalmologist who conducts the surgery, and then the child is fine. So glaucoma, like I said earlier, is not a death sentence. So that is that for the treatment plan. And again, let's move to developmental glaucoma associated with systemic anomalies. Associated with, okay, let's look at ocular anomalies before I go to the systemic anomalies. So developmental glaucoma with associated ocular anomalies. So now there's a glaucoma associated with iridogenosis. So in this case, you find out the glaucoma is associated with aniridia, it's associated with familial iris hypoplasia, and then there is microcornea. So there's also glaucoma associated with iridocorneal dysgenesis. So these are complex matters. I will just state it, but in in the what do we call it now, in the slide. I will take time to talk on this, but because I want to be so basic and simple, because the general public are also joining in, so I don't want to appear too complex to them that they cannot follow up what I'm saying. And again, so in developmental glaucoma associated with systemic anomalies, so there is a glaucoma associated with chromosomal disorders. There's also glaucoma associated with phacomatosis. There's glaucoma associated with metabolic syndromes such as Loeys syndromes, etc. So this is that for developmental glaucoma. So quickly, let's go to primary angle glaucoma, and then we call it a wrap for today. Now, in primary open glaucoma, what do we mean by primary open glaucoma? Now, if there is open angle, it means that there is also a closed angle. So in primary open glaucoma, there is no obvious systemic or ocular cause of rise in the intraocular pressure. Because, why do I say so? Because you find out that the structures are normal. Aqueous should be able to flow out as it should without giving to a rise or a build-up in pressure. But yet, glaucoma is setting in. So this is what we call the primary open angle glaucoma. So it is a slow progressive raise in intraocular pressure, usually less than 21 millimeter mercury. And maybe a few occasions it might get to 21 or above, but yet most times it is below 21 millimeter mercury. So what are the risk factors of primary open angle glaucoma? One, the first risk factor, like always, will be increased intraocular pressure. Family history. If someone has a glaucoma in the family, likely its other will have it. We are not saying that everyone who has glaucoma, if you have glaucoma, all your children or everybody in your family has it. But because glaucoma is a silent thief of the eyesight, it is important that once someone has it, every other person should go for a test. And even if nobody has it, it is expedient that you, just for your own routine, your health is your responsibility, you go and check yourself for glaucoma. So family history is a risk factor. Also age. So as we age, the risk of having glaucoma increases. Also race. It is more significant in the blacks. So glaucoma is more, primary open angle glaucoma is more significant in the blacks. So we are more susceptible to it. And also myopes, people who are myopic, is also a risk factor for glaucoma. Also the central corneal thickness is also a factor. So the thinner the central corneal thickness is, by the thinner it is, apart from the causing underestimation of IOP by applanation tonometer, it is considered as an independent risk factor for primary open angle glaucoma. Are we together? And also diabetes. Patients who have diabetes are also at risk of having primary open angle glaucoma. Also people who smoke, whatever, either it's cigarette, shisha, loud, whatever it is that you smoke, it is a risk factor for having primary open angle glaucoma. Another risk factor for it is high blood pressure. This is why we will want to always insist that you manage your pressure. If your pressure is not managed, it's a risk factor for primary open angle glaucoma. Also, thyrotoxicosis is also a risk factor. Also, use of steroid is also a risk factor. So these are the common risk factors we have that are associated with glaucoma. So we will call it a day for today. In my next class, I'll begin to speak on the what are those ophthalmoscopic features we see, or what are the structures we are to look at in assessing glaucoma. So thank you for joining. Do well to watch the video again to get what I'm saying. Do well to watch part 1, part 2, and this is part 3. Do well to subscribe. Do well to comment. Do well to like, and do well to share this video. I am Dr. Wisdom. Thank you for joining. God bless you. See you next Sunday by 5 p.m. for another session. Good day.